I'm Lygia Stewart. I'm the co-chair. I'm a professor at surgery at UCSF, and I have a fellowship in quality and patient safety. And I've been interested in bile duct injuries for decades. We started out, I had one talk, this talk, and then as the COVID crisis took people off the program, I said, okay, I'll do that talk, and then literally within days of the conference, I said, okay, I'll do the last talk. So I apologize, you get to hear me for 3 talks. I'm gonna try and make it lively. I apologize in advance. Okay, so let me talk about human factors in bile duct injury, something near and dear to my heart. No disclosures. Larry Way and I studying this decades ago, and we basically discovered there were 2 types of injuries. There are those that are an active mechanism where you've misidentified ducts as the cystic duct and you actively divide them, and then there's passive mechanism where you're working too close and you get a narrowing of the duct. But both of these are both based on misperception. If you think about it, the most common is what we call the class 3, which is a resectional injury, where the cystic duct's mistaken for the common, tissue overlying is not removed, and then you don't ever see the common hepatic duct, which is actually really interesting. Very rarely is that seen. This is the perception. This can be the reality. And these active injuries account for 75% of these laparoscopic bile duct injuries, which in most cases, they're not detected intraoperatively, which really underscores the fact that there's a visual perceptual illusion that's associated with these. So what about visual processing? I've sort of delved into visual processing to sort of see, well, how do we even see anyway? And it's actually pretty illuminating. Early on, Van Helmholtz, who looked at eyes, said, you know, that it's really optically poor. The quality's so bad, he can't even imagine vision to be possible unless there was unconscious inferences, assumptions and conclusions from incomplete data based on previous experience. Now that is actually how we see. Fast forward to the current day, great book by Donald Hoffman describes how the brain uses heuristics and pattern matching to create the visual image, and it's almost completely unconscious. What you see is what you create. You fill in the missing gaps, it's effortless and it's unconscious. This thing's a little slow. So what about visual construction? You see a space, your eye takes cues from what you put in that space. Not too fast. Forget it, it's not gonna go back, okay. You can simplify the problem, you fill in the missing gaps, as something called visual completion. You do this all the time. Here's an example. So it went too fast, okay. You see a white triangle here that's not there because your brain says it has to be there based on visual completion. And people say, well, the laparoscopic view is 2D, but everything's 2D. Vision scientists say the retinal images are inverted and 2-dimensional. They say that there's an infinite number of 3D images that are compatible with any given 2D image, yet the brain constructs a 3D image. Look at this picture. So look at this, it looks like a guy standing next to a chasm. It looks very convincing. It's like there's a delay, okay? Yet, it's not a chasm at all. It's a brilliant artist who he gave me credit, he allowed me to do his pictures. Even when you're looking at it, you can't accept that they're not aliens floating in space. And what about the laparoscope? The laparoscopic environment is different. You've got the lighting from the scope, it's fixed. Your lighting is from below. You don't have haptic input. So let's go through some of those. What about lighting from the scope? The brain assumes that light is from above, yet laparoscopically it's generally from below. And that affects how you determine surface shape. And you can see lighting really changes your surface detail. Magnification, we think this is our friend. But in fact, when you think about how we divide shapes into parts, the acuteness of the angle determines whether there's 2 different parts there. And when you have an obtuse angle, you think that's all one piece. Well, what happens in magnification is the visual construction of boundaries is changed. As you magnify the image, now you can see the cystic duct and the common duct look like one thing as you magnify the image. Just from magnification, that's exactly the same picture. And then finally, and this is really surprising, you're not even seeing what you think you're seeing. You look around this room, you think you see this room. 98% of what you're seeing right now resides in what's called visual short-term memory. You're really only seeing your last glance, the last 2% of whatever you looked at. The brain puts that all together in something called visual short-term memory to create this rich visual scene. And so what will make you look again and recreate the moment? People say this might be a reason for change blindness. The thing that will make you look again is action and movement. And that's key. You got to use that in the operating room. Haptic input is also really important. The visual cortex and both haptic input both map to the visual cortex. In fact, it contributes to visual perception. Early on, we map our vision onto our haptic thing. If you look at ambiguous visual data, we resolve it with haptic, and surgeons implicitly use this. But we lose a lot of it laparoscopically. Action is also really important. It informs vision. If you take kittens and you don't let them have active action, they don't develop vision. It derives attention and vision. People don't see objects they don't attend to, and they can't prevent themselves from looking at things that are in motion. People say that athletes have better vision because of their superior physical abilities within a context of motion. And there's many things in visual processing that are really create our 3D world, not our two eyes, that are only possible during motion, which I list here. I can't go through them in detail, but I invite you to look into this further. Framing is also really important. We frame things that defines the relevant data. For example, rule out MI tells us how to focus our thoughts. Depending on how we frame a situation, we will either deem data relevant or irrelevant. So you may have a frame, you get the data, things look good, you re-elaborate that frame. As you get incongruous data, you'll either say, no, it's probably just an error, it's probably nothing, or you can say, no, this is a problem, I've got to reframe. And that's what we've got to do, is learn to reframe when needed. So several factors facilitate intraoperative bile duct injury recognition, but the most important one is when the surgeon changes their frame to suspect a bile duct injury. In looking at 300 bile duct injuries, if they just opened or described irregular cues, they rarely detected it. But when they said, there's something wrong, we've got to consider a bile duct injury, the detection rate was 95%. Here's some examples. The cholangiogram on the left, you can see the frame. If you say there's no common duct stones, that's correct. But if you say there's no hepatic duct, then you know it's a bile duct injury, and on the right was a directed one. So the important thing is to frame correctly. Ductal tubulostructural, that's a biliary radical. Irregular cues, think about a bile duct injury. And finally, working memory is really important because inflammation correlates with higher incidence, but it's because high working memory and stress causes attentional narrowing with a more focus on the local features, not how they're globally constructed, a tendency to miss the forest for the trees. So the surgeon's attention toward bleeding and visibility will actually mask their proximity to the bile duct, focusing their attention just on the bleeding or inflammation, not the global field. That's really important to consider. So it's complicated. There's a lot of noise, the situation's changing, you've got working memory, you've got attention, computational capacity, relevant cues, and out of that, you've got to take the best action. And then, of course, there's hindsight bias. The people come back and say, no, that was really clearly a mistake. Everyone can see why they made that mistake. What's wrong with them? What kind of idiots are they? But when you're working at the sharp end, it's a completely different scenario. There's multiple scenarios. No one can really see what you're like at the sharp end. Hindsight does not equal foresight. So in conclusion, this is useful knowledge. You can use this to kind of think about how you process things, your perception alterations in the laparoscopic environment, insight into the misperception. Be aware of how stress affects your working memory and your global awareness. Adapt this, how laparoscopic environment changes things. Utilize all haptic cues available. Movement is your friend. Fresh eyes. You ever seen the movies? Fresh eyes, fresh eyes? Makes your brain reconstruct the whole scene. Think about that. Have you ever dissected something, started here, and then worked over here, and then come back and went, wow, I can see things I didn't see before. It's probably because your brain just had to reconstruct the whole scene. So think about that. That's interesting. Get the big picture, actively seek a global view. Frame abnormalities as normal anatomy misidentified, and actively seek out findings that might indicate or facilitate a bile duct injury, and put that in your mental model. And here's a bunch of references for future reading. And so this is recorded. You can hump these up. If you want, email me. I'd be happy to send you. I have files on this topic. Thank you. This is Lake Mead.